Hello, my name is Roshan. I am one of the Senior Clinical and Education Fellows on Intensive Care at St Bartholomew's Hospital in London. Okay, so first some general principles about the drug chart. Do remember to check the drug card daily. You may have seen a similar type of drug chart on the ward, but you know this is an intensive care one because it says Integrated Critical Care Charts. Do check that you've got the right patient. The sedated and ventilated patient will have a drug chart at the end of the bed. Take note of the patient's allergies. The first page contains a section where you can prescribe a number of stat or once only doses of medication. On this page there is thromboprophylaxis, mechanical and pharmacological. Most patients in ITU will require some sort of thromboprophylaxis. On the next page are antimicrobial prescriptions. Of note, if you have to cross off any drug, put a line through, initial and date. If appropriate, you can write the reason for de-escalating the treatment. With antibiotics, do remember to write the indication and the course of treatment. Sign and your bleep number. On this page are doses for oral anticoagulation, but we are unlikely to be requiring this for COVID-19 patients. Here can be prescribed nebulizers and oxygen. And then we are on to regular prescriptions. So the standard ones that are likely to be prescribed in most, if not all, of our ITU patients are lansoprazole for gastric protection, Carbomer and Hypromelose eye drops, because sedated patients cannot blink, and these provide eye care to avoid ulceration or keratitis of the corneas. Chlorhexidine mouth gel. This prevents VAP, or ventilator-associated pneumonia, and a chlorhexidine body wash. Many of our patients will have developed some form of ileus through their intensive care stay. So laxatives are appropriate, and we tend to prescribe Senna and Docusate. On this page, you can prescribe as required medications. On this page, you can prescribe a number of infusions. As you can see, many of these are pre-populated with their doses and concentrations. We will provide crib sheets that will have the appropriate doses, prescriptions and ranges for a number of these infusions which are common in intensive care. You're probably going to encounter Hartmann's as our usual fluid of choice, and this can be prescribed as a background infusion rate or as a stat bolus. For cardiovascular support, noradrenaline is common. Adrenaline is also used. Here I have written vasopressin. From a sedation point of view, our usual medications are propofol and fentanyl. On this page are some more PRN or as required medications. As you can see, they are pre-populated. Potassium, magnesium, phosphate, saline flushes for arterial and central venous lines, and frusemide to unload the patient of fluid. These require a signature and a threshold which the nursing staff will titrate their medications to. On this page, further infusion prescriptions can be written. Ignore this part because the renal replacement therapy is prescribed on a separate page. Many of our patients will require IV insulin on a sliding scale. This requires a signature, and the nursing staff will apply an appropriate protocol. Ditto, enteral nutrition, a signature and a separate protocol exists that will be adjusted by the nursing staff. We try and use enteral nutrition, but on occasions we might have to use intravenous nutrition if the patient is unable to absorb from the enteral tract. Blood products can be prescribed here. This is a record of the actual intravenous medication and infusion that has been administered. The nursing staff will fill these out. It is unlikely that many of our patients will require an epidural, though some may have patient-controlled analgesia to help address pain issues as they are waking up. This is the intravenous insulin protocol. This chart is to prescribe an anticoagulant for renal replacement therapy. The decision to commence renal replacement therapy, and indeed which anticoagulant to prescribe, rests with the consultant. The hemofilter requires an anticoagulant because blood is liable to clot when it is taken outside of the patient's body. Citrate is our standard anticoagulant of choice, and this will be ticked in most instances. The details underneath are selected and adjusted between the nursing staff and the consultant. On occasion, heparin may be used as the anticoagulant, particularly in cases of liver dysfunction. If the patient is actively bleeding or particularly coagulopathic, then no anticoagulant may be prescribed. This has been a brief introduction to prescribing in ICU. I hope now that you are a bit more familiar with how we prescribe and what we prescribe. The decision of what to prescribe, how much and how often, lies with consultants or other senior decision makers. We do not expect you to memorize lots of numbers. We will have crib sheets available to guide you in how to prescribe the various drugs we have. Also, please ask for help from us, our nursing staff colleagues, and our pharmacy colleagues. And there are also online resources that are available. The key things to remember are to check that the correct patient has the correct drug chart, make note of any allergies, do a daily check of the drug chart, and make sure that whatever prescriptions are available and prescribed are appropriate, and consider whether they can be de-escalated or stopped. Thank you very much for your attention, and thank you for coming to support us and working with us as part of our team.